Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Hello, and welcome to our podcast. Today, we're diving into rare liver diseases through a woman's health lens. I have two incredible guests joining me today. Dr. Tatyana Kushner, she's a hepatologist and associate professor at Weill Cornell Medicine, and she leads a women's liver health program and researches everything from viral hepatitis and pregnancy to liver diseases that are unique to women. And we have Dr. Andrea Goldstein, who is the Senior VP of Global Medical and Scientific Affairs at Mirum Pharmaceuticals and a nurse practitioner by training. Andrea brings 20 plus years in liver disease, from treating patients on the front lines to leading drug launches in hepatology. In this episode, we're going to hear all about their personal journeys and talk about why rare liver diseases need a woman-focused spotlight, and explore how we can improve the care for all patients. It's going to be insightful, and knowing these women, it's going to be very down to earth. And we're going to talk about science, medicine, and real world impact. So let's get started. To kick things off, I'd love to hear about both of your backgrounds. What got you focused on liver disease and why the emphasis on women's health? Tatyana?
Sure. Well, thank you so much. And I think, sometimes you don't know how you came to where you are, but you kind of look back at the steps and then it all makes sense. But I did my medical training at Mount Sinai in New York. And I think really pretty early on in my medical training, I was exposed to the treatment and management of liver disease. Mount Sinai is a big liver center. And so even as a medical student and a resident, I began to take care of patients with liver diseases. And I think what was really interesting to me is, well, one, the physiology and how important the liver is in terms of your overall health and all the implications of potentially having liver disease, but also the full spectrum of liver disease, from having just mild liver test abnormalities that may be related to even medications, to having what we call decompensated cirrhosis. So, really advanced liver disease where people are among the sickest in the hospital. And then they can undergo liver transplant and really begin a new life. So, that really the spectrum of liver disease, the patients that I was seeing, that's what drew me to liver disease in general. And then in regards to the women's health lens, I when I was a resident, I started thinking about, okay, well, I think I'll specialize in liver disease, gastroenterology, but I kept thinking about how there are really important women's health aspects of all diseases, but in particular, I started to think about it in GI and liver. And I initially was interested in actually pregnancy specifically, and to try to understand how this big event in the lives of many women can alter the natural history of liver disease, but also how there are specific conditions that can occur during pregnancy that can affect the liver and your health overall. And I felt that this area was so interesting, but also so understudied, and there were so many questions that we really didn't understand. And so people become pregnant, and then we have to counsel them about their potential risks. And we don't necessarily have the data to guide our discussions. And so I think that was my early um, kind of interest in liver disease, and the intersection really between women's health and liver disease. And in particular, I was very fascinated by the interaction between liver disease and pregnancy. And then as I moved forward in my training and really began to understand liver disease better, I began to see more and more of these gaps that I felt were really important to address, and that we can conduct research in order to improve our understanding and really improve the lives and health of women with liver disease.
Thank you so much. I mean, that's so interesting. You must have been drawn to this area for women's health because you probably were noticing a lot of your patients who were pregnant with different liver diseases, right?
Right, for sure. And then maybe this had something to do with it, but when I was a fellow, and when I was training in gastroenterology, I during my last year of fellowship, I became pregnant with twins. And so it sort of also began to feel a little personal, just, going through pregnancy and thinking about how do these women who may have this underlying condition navigate this when there are already so many questions at baseline, but then how having an underlying condition can influence how the events that occur in pregnancy and how you go through the pregnancy period. So that was the personal aspect of it.
Absolutely. And so, before we get into my personal aspect of it as well, because I was one of those women who had cholestasis during pregnancy and had no idea about what it was. And honestly, I credit my doula with telling me to go get checked. But I want to turn it over to Andrea. So, Andrea, you have such an interesting story as well. You started as a nurse practitioner, essentially a nurse practitioner on the front line of liver disease management. And I believe you said you were working in Los Angeles back in the 90s. Tell me more about that and tell me how you went from a healthcare provider to getting into medical affairs and biotech. What was that journey like?
Yeah. So thank you. Thank you. My story is not completely similar to Tatiana because I'm a nurse practitioner, not a physician, but it was just sort of an evolution and through relationships with other people. So I moved to Los Angeles as a travel nurse. So I was an ICU nurse that took a position at UCLA hospital working in the ICUs. So I floated, where you move back and forth between a couple of ICUs, between the cardiothoracic ICU that had pediatric and adult patients and the liver transplant ICU, which had all adult patients. And in that time period, UCLA was really a powerhouse for liver transplant. I don't know, they were doing 250 to 300 liver transplants per year, both pediatric and adult. And I built relationships. I built relationships with the surgeons and with the hepatologists. And I was thought of as someone that they could rely on taking good care of their patient in the ICU. So I eventually became a liver transplant coordinator. So setting up liver transplants, educating the families, coordinating, the operating room, getting the organ procured, and to the operating room for the surgeons to ultimately perform the liver transplant surgery. Uh, I decided to do actually a master's in public health before I did my nurse practitioner degree. And my master's thesis was hepatitis C in the California prisons. And I got really interested in viral hepatitis because drugs were emerging and I had worked on some clinical studies. So this is in the days of pegylated interferon. And this was a high unmet medical need, and I got really interested in viral hepatitis. And so my master's thesis was on hepatitis C in Los Angeles County, the burden of it, where the patients are treated, and that's how I really got interested in liver disease was through my work in the ICU and then through my master's program at UCLA. I decided that just knowing about hepatitis C and liver disease wasn't enough, so I decided to pursue an advanced degree in nursing, and I did an NP, nurse practitioner degree, and job came open for in the pharmaceutical industry, and it was really random. One of the hepatologists had said, this so and so, this person is actually resigning from her position as a clinical specialist. I think you should apply. And I said, "Well, I'm not sure, I don't know much about it." And he said, "You should apply." And so I applied for the role and I interviewed against other candidates and I ultimately got the job at Roche Pharmaceuticals as a clinical nurse. Well, it was a clinical specialist, educating on how to inject pegylated interferon in patients. And so that was my start into liver disease and into the pharmaceutical industry 23 years ago.
That's fascinating. And first when you started talking about your early career as a travel nurse, one sometimes may think and be biased to think that a travel nurse may go to like Cayman Islands, St. Thomas, do something more fun. But you went to one of the hardest, like most challenging environments in Los Angeles. And during that time, right, like viral hepatitis was a big deal. How did you even navigate through that? How did you make the choice to go there?
Yeah. it wasn't very academic, to be quite honest. I was living in Chicago as a nurse, and it was September, and I had 2 options. I could go to New York City, I could go to LA, okay? And so the decision was, do I wanna go to New York and face another winter? I grew up in Minnesota. I lived in Chicago for 2 years, worked as an ICU nurse for 2 years, so I had the requisite experience to go as a travel nurse. So let me just see. UCLA, beach and sun, or winter. And I just made the choice. I'm like, I'm going to California." So,
I understand you now.
17 years in LA. So, I don't know, navigating it, I don't know. I guess I just felt somewhat fearless. I was 25 years old. So,
I don't know what to say. I think both of you have such amazing and incredible career paths that are not often easy. And I do want to take the opportunity to thank you both for being on this podcast and sharing your personal journeys and stories. And I think I want to take the opportunity as well to help women with rare liver diseases, especially in pregnancy, because it's, again, as I mentioned, something that I personally went through. And at the time that I went through this, I didn't know that it was possibly something that ran in my family. And my aunt actually went through 2 pregnancies with the same symptoms that I had, and both pregnancies were fine, but her quality of life during the itching was the worst. She had, open wounds on her skin. It was something that was really difficult for her to navigate, and then when I started experiencing my symptoms, it was basically a month before my baby was due, and it was one of the scariest moments ever. And had I not been connected somewhat, in the liver space and working in this space and medical education for the past 13 years, I don't think I would have known to push my healthcare provider to probe and investigate further and help me to have a best outcome for myself and for my child. But the pregnancy aspect, I that was something that I was not aware of at all. So,
Yeah.
Tatiana, I
Yeah.
feel like you want to
Yeah.
say something here to
No,
that.
no, I think I meet a lot of women who have similar experiences, and I think one of the scary parts of intrahepatic cholestasis of pregnancy is that it seems to come out of nowhere for many people. They have no underlying liver disease. They have no underlying any disease, actually. Many women are otherwise completely healthy, have never had any, issue, and on top of that, there's this feeling often, I think, during pregnancy is kind of dismissing symptoms because there's so many different symptoms. And so I've had women say, well, I was really itchy, but I just assumed that was pregnancy. I assumed that that's, normal for pregnancy. And then even on the doctor side, sometimes if there's something maybe atypical about how the cholestasis of pregnancy is presenting, they may also dismiss it. For example, I've had patients come to me that say, well, I started developing symptoms at 16 weeks of pregnancy, which is early. And the doctor said, well, this can't be cholestasis of pregnancy. That's too early. And so they don't even do the tests that are needed in order to make the diagnosis. And then I think the other aspect of cholestasis of pregnancy is that it is a bit very heterogeneous condition. So every woman experiences it differently. Some may have very severe debilitating itching. Some may not have such severe itching, but then when you check the blood tests, there are markers that suggest that it is very severe. And of course, the scary part of it is that potentially, if severe, it can affect the baby's health. And that's really, really anxiety provoking for a lot of women. And so it's a condition that I think we still have so much more to learn about. But the first step, of course, is recognition and getting the word out there that this is something that can happen. And I think Andrea at Miriam and others are really thinking about how we can really understand this condition better. Is it how many people have a genetic predisposition to this that we can potentially be aware of so that we can initiate screening earlier, potentially, or even in the future treatment. Are there better treatments that are on the horizon that can really help people feel better and also optimize their pregnancy outcomes?
Absolutely. And I think that there are so many, obviously, as we're learning about this topic, opportunities for us to share information about, rare liver diseases. So, just turning it over to Andrea, could you give a few examples of rare liver diseases? And in your opinion, what unique challenges do women face compared to men?
Yeah. PBC, primary biliary cholangitis, is a disease that mostly affects women, but the impact on women is that it's always was thought to be a disease of Caucasian women, like Northern European, blonde hair, blue eyed women. And over the years, as more drugs have come to market and we've had patient registries, larger data sets, we've recognized that number one, more men than we had probably expected have PBC, and that women of color have PBC, but perhaps they have less access to care. So you see it. I'll give you an example. I work a lot with patient advocacy, and I think that's critical, working with patient advocacy in rare disease to really, bring the voice of the patient forward. And and to provide education so patients can advocate for themselves. And I think, Giovanna, you had to advocate for yourself with ICP. But a woman with from the PBC Friends of PBC Foundation was an African American woman in Chicago, held an event, and I was taught really like more than 20 years ago that PBC is really a Northern European. It's like Scandinavian women, women from the UK, Northern France. And here's this woman standing up on the stage saying, "I have PBC. I'm an African American woman, and I'm, leading this, advocacy group to share the voice of women who look like me." And the room was filled with 50 other patients, Hispanic, white, from all over the United States. And so I think what we haven't done a great job of is really reaching and closing the health disparities racially. And so I think working with patient advocacy can help us do that. And for pregnancy, ICP, intrahepatic cholestasis of pregnancy, working with ICP care and really providing some resources. But here's the thing, as Tatyana had said, women just normalize it. They'll say they have pruritus in their pregnancy and they think it's just pregnancy. But and they may not understand the risks that are going along with the pruritus, which may be caused by elevated serum bile acids in their serum. And certain levels can predict whether or not the baby would be born still or if they're going to have maybe not a great outcome, perhaps staining on delivery and so forth. So we have a lot more to do in the pharmaceutical industry and advocacy and working with physicians to really educate the community, educate, providers, OB, hepatologists, advanced practice practitioners, midwives, and patients themselves.
Absolutely. And I think that speaks to my experience, like down to a T, right? In terms of more education that is needed for healthcare providers. So when I had first experienced my symptoms, we were on our last baby moon. We were trying to have as many as possible so that we could prepare for the baby in a good way, right? So we're in this like very like beautiful town called Elora in Ontario, where I live in Toronto, so it's very close by. And I start experiencing these symptoms, and it was like 6 a.m. in the morning. And I went to a walk-in and I said to them, "Can you guys do testing?" So it's like, what is it, Tatyana? It's ALT, AST, bile acids, right?
Yeah. Bile acids, right. The bile acids is the test that makes really the diagnosis. And the liver test help also. Yeah.
And they looked
Mhm.
at me like I was crazy and they said, "We don't know how to deal with this. Like, you need to go into the hospital."
Right.
So off I went to the hospital. And as it turned out, I met the person who was the professor of my OBGYN who resided in Toronto. So he was able to kind of go through the testing process and say that this is what it was. And he didn't make it alarming, but he said, like, once I come back home on the Monday, which we went home Sunday, we cut our trip short. It was too stressful that I should call my OBGYN, call the hospital and go in. And as I was doing that, they were dismissing me, completely dismissing the condition, the symptoms, and telling me I don't have to worry. I should come in for my regular appointment, which was on a Wednesday versus the Monday. And honestly, I'll tell you guys, by Wednesday, my baby was already here because the situation was so dire that once I went in on Monday, they were like, it's getting worse. You know, your liver enzymes are getting worse. Even though I was on treatment, I don't think it really works that fast, right?
Yeah, the ursodiol is the first line treatment, and it does take some time to work, but also it only works in maybe 50% of people, so it doesn't work for everyone. And so once we diagnose it, we can start the treatment, but it doesn't work. And the other thing is, even to make the diagnosis, the blood test that we do, the bile acids, it can take up to a week to come back. At many hospitals, even academic health centers. So there's often a delay to diagnosis, and time is of the essence, as as you had experienced, because once a diagnosis is made, then if it's severe, then the recommendation is earlier pregnancy delivery. And so if you're already at 35, 36 weeks, then it becomes a very stressful situation where it's like, wait, come in immediately. We need to deliver.
It was exactly like that. We were hanging out at the hospital. I remember my husband and I, we had our computers out, we were doing work, we were like enjoying ourselves, right? And then they came in and they said, "Yeah, it's getting worse. We need to do like the induction." And I was like, "What? Nobody told me like this is what's supposed to happen." But I always say all's well that ends well. But it really gave me a ton of awareness about this condition and how it potentially runs in my family. And that's sort of how I kind of connected with you guys as well, if I recall, was that wanting to explore a little bit more about this and my experience and connected with Andrea, shared my story. And, I hear now that you guys want me to get some genetic testing. Is that right?
Yes, we would love it.
Cool.
Uh, yeah, I agree. I mean, I've lowered my threshold for genetic testing. One, because women are genuinely interested. To try to understand, that they are often in similar positions as you, Giovanna, where this seems to come out of nowhere. And honestly, a little bit traumatizing, I think, to some, because, it's really scary to not only have these symptoms that you've never had before, but also be um, concerned that your baby's at risk, right, during pregnancy. And I think the genetics is really a step in the right direction in terms of beginning to understand this condition better. To me, it's a little, unbelievable that in this day and age that many women are going through something like you, where there are just so many unknowns about, why should we not have more data to guide our management to be able to treat this condition better? And when in fact, still, I see many people that are in your position that is like, well, I don't know what will happen next. And I don't know if your bile acids will increase. Well, I hope the bile acids will go down. I hope that your baby will be okay, but still not too much, not enough data. I mean, we're getting more and more data, but not enough data to guide it. And I think the genetics is really a step in the right direction, because as we accumulate more data on the associations of the genetic findings with the ICP course and outcomes, then we can begin to provide better counseling and guidance. So I'm really excited about this. The increased availability of being able to do genetic testing. And then, of course, genetics is not everything. I think we also need to understand other factors. Obviously, there's always genetics, there's environment, there's, you know, different predictors. So, for example, there seems to be an association of developing ICP with IVF, or there are certain uh, ethnicities that may have higher prevalence of ICP that may be related to genetics, but perhaps it's also related to environment. But I think we need to continue to work hard to learn more so that other people have a better experience than you did. And then as we learn more, hopefully that will translate to treatments that we can actually use. But I think the challenge with developing treatments that we can use in the context of pregnancy is studying. Studying medications in the context of pregnancy. And Andrea knows this very well because you did have a clinical trial, right, to study treatment of ICP in pregnancy. And maybe you can share about that experience and the challenges that came with it, right?
Yeah, it was very difficult. So we attempted a randomized clinical study assessing the use of an IBAT inhibitor in women with ICP. And we had screened over 1,000 women. I believe uh, or approached 1,000 women. 26 women went through screening, um, and 4 women ultimately enrolled into the study and were dosed. 2 were at a high dose of 80 milligrams of maralixibat, and 2 were at 20 milligrams of maralixibat. And they, we closed the study early. Um, 3 of the women had really a strong pruritus response. So the endpoint was looking at improvements in cholestatic pruritus related to intrahepatic cholestasis of pregnancy, and 3 had a great response. But really, the challenge is approaching women. So pregnancy is a finite period. So when you do a clinical study and you're trying to enroll a clinical study, you have, not a really long runway, but you can look at your enrollment over, maybe a year, 6 months. You set target goals, but you can always open up more sites to help with enrollment, and that wasn't really helping us with ICP. And this ICP happens, and Tatyana, you will know this better than I do. It can happen at any time during the pregnancy, but you do see it more commonly, I believe, in the third trimester of
Yeah,
pregnancy.
for sure.
So in that third trimester, so let's think about that. That's 12 weeks. And you have to screen a patient, you have to enroll a patient, and then you have to dose a patient. And oftentimes these women do have delivery early, anywhere, I mean, 34 weeks, but 35, 36, 37, maybe at the latest.
Right.
That the delivery is then scheduled. And so this is a short amount of time to get women enrolled into a clinical study. And then on top of that, do they really wanna take a medication that is, quote, "experimental"? And
Hmm.
what harm will this cause their infant? What harm will it cause them? And so there's lots of questions. So it's really hard to do studies in pregnant women just in general.
Right. And that's really the challenge because then we have someone again like Giovanna or others who may have very severe ICP and they may have started the medication like you did, the ursodiol, which is not helping them. And their ICP may be getting more severe. But then the question is okay, so we have this IBAT inhibitor that there was a trial of in 4 people. We feel comfortable with the mechanism of how it works, and we feel that it may benefit you. And if you take into context any other medication that's used in pregnancy, very few have dedicated pregnancy studies. We use Miralax all the time for constipation in pregnancy. There's no randomized clinical trial of Miralax in pregnancy or any other medication for that matter. But yet, uh, I think there's also a big hesitancy because obviously you want to make sure it's safe and you really want to weigh the risks and benefits. And for example, I have a patient right now who has very severe ICP. Right now, as we speak, I've been speaking with her every day. She's not sleeping at all. She's extremely pruritic, very itchy. Bile acids are very high, over 100. I brought up she had a prior pregnancy, which was complicated by a preterm delivery that was not a good outcome. She also had ICP. She has positive genetic testing. And here we are discussing potentially using this medication, but she and her maternal fetal medicine and obstetric providers feel very hesitant. And really, actually, more so, even I think, from her OB providers saying, well, you know, we just don't have that much data on this medication. And so it's really a challenging situation because this patient is really miserable and has been miserable now for a few weeks and is not sleeping. And should we not be thinking also about not only the outcome for the baby, but for the patient's well-being as well? And we wish we had something to offer her, but it's really a challenging situation.
Yeah. We at Mirum, the pharmaceutical company where I work right now, we do have a compassionate use program, and uh, and so physicians, if the drug is commercially available, they have an option to write the product off label if they feel that the risk benefit is worth it for the patient, so they can make a decision based on whatever clinical evidence is available to write a drug off label use. Or we have a compassionate use program, which is evaluated on a case by case basis. Uh, there's a publication that's been accepted looking at 3 cases from our compassionate use program where the women all had a genetic cause of cholestasis and in ICP, and they responded well. But this is, a select group. This is a compassionate use program, and Tatyana actually has experience and published a case of, and this is a genetic cause of cholestasis. Wasn't it BRIC? BRIC, yes. Is it and had ICP in both first and second pregnancy, but I believe you wrote the product off label, didn't you?
Yes. Well, she did have a possible suspected PFIC. The BRIC, PFIC diagnosis is a little bit challenging to distinguish. But what was interesting in that case is that patient was a neurologist. She was a medical provider, and she was pushing me to prescribe it. I mean, she really took charge and guided her management, and her husband is interventional radiology, and both of them together said, "This mechanism makes sense. We don't see any problem with it. We think that it can really help." So she was actually telling me that she really wants me to get this medication for her. So she was really guiding her care. But I think that takes a really unique type of patient. I mean, obviously she was in the medical field, which helped, and really had a prior pregnancy, which again she didn't have an ideal outcome. And then she did very well in the second pregnancy compared to the first pregnancy, and she's still very thankful for it. And she wants to do advocacy. She's speaking with Miriam and the ICP. Um, Patient groups in order to kind of tell her story. She actually spoke to the patient that I'm referring to who's dealing with it now. So she's very, she feels like she's really benefited from this, and she wishes that more women could kind of access this and have an outcome like she did.
Well, let's get her on the
Yeah.
podcast, guys.
Yeah. Oh, she would be amazing on the pod. We
Yeah.
should have we should have brought her in. She would be
Exactly. I
amazing.
agree.
2.0. Yeah,
Yes.
absolutely. So,
Yeah.
really, it sounds like there are so many different gaps, right? From even like going back into like preconception counseling. Tatiana, I know you write about this counseling with
Mhm.
liver specialists, earlier collaboration, to
Mhm.
essentially with OBGYNs to have a plan in place, right?
Right, right. Yeah, and I think this is an example of where interdisciplinary management and collaboration is really critical. Honestly, a lot of times patients with ICP, they don't see a liver specialist. They're really managed in the obstetric division, but I think usually patients who then develop a more severe case, then we become involved. And because I've had an interest and have done some research in this topic, I tend to see a fair number of patients with ICP. But I agree, the preconception planning and counseling is very important. And for example, in someone who's had ICP before, even just making them aware about the risk of recurrence. So there's genetics aside, there's a very high risk of recurrence. So we just had a paper accepted for publication that looks at a large cohort of a few thousand women with close to four, over 4,000 women with suspected ICP in a New York City health system. And we looked at those people who had repeat pregnancy and the recurrence risk, and about 70% of these women had recurrent ICP in their subsequent pregnancy. So when you do the preconception counseling, I think that's the first step to make people aware that there is a high risk of recurrence. However, sometimes people ask, well, should I not pursue further pregnancies? And I never say that you shouldn't, but now that you're armed with the knowledge, you're more informed. And if you develop symptoms early on, obviously let us know. Don't dismiss the pruritus. But also, maybe there's a role, and it's not in guidelines per se, but maybe there's a role for earlier testing. Let's check your baseline liver test and bile acids to see where you're starting, and then check at least once every trimester to see if perhaps there's early onset. Um, and I think that helps people feel less anxious, I think, going into a subsequent pregnancy for sure.
Absolutely.
Tatyana, I listened to that presentation at EASL. I think one of your medical students, is it Nina
Yes,
Rodriguez,
Nina.
presented it.
Yes,
Yeah, she did
yes,
a great job. That was really,
yes.
and so 70% of the women who've had ICP in the first pregnancy couldn't have it in the second. And there's a small study from Arizona that showed that it's, I think, 71% have a genetic cause if they've had it in their first pregnancy. So I would be curious to actually see what we could do to genetically test those women who had it in their
Mhm.
subsequent pregnancies to see, like, what is the rate?
Yes.
Because you also had a really high Hispanic population, if I'm remembering the
Yes.
study correctly. And
Mhm.
and talking about health disparities, what
Mhm.
I understand about ICP is it does predominantly impact, say, East Asian women and South American women, so women of Hispanic descent. We see it less so in like European women,
Mhm.
although one of the world experts is from the UK, and she's
Mm.
Kath Williamson. But Hispanic women, and we know less about ICP in African American or Black women of the
Mhm.
rate. They seem to be a little bit lower. But your
Ri
study did find a significant population of Hispanic women, I believe.
Yeah, it did. We in our cohort that was the suspected ICP, actually in this study, it was over 20% that were Hispanic. So 1 in 5 of the people that had suspected ICP were of Hispanic ethnicity, compared to maybe around 14% in the control populations, the pregnant people without ICP. And then one other thing that we did in the paper is we characterized the suspected ICP patients between different groups based on the European Association for the Study of Liver, the EASL guidance, which uh, has begun to actually risk stratify to say, well, once you have suspected ICP, similar to Giovanna, what you had itching. So at that point, you had suspected ICP, but there
Mhm.
was no official diagnosis made. And at that point, when you check blood tests, you can determine which group someone is based on whether they have elevated liver tests. That's the first step. And then also if they have elevated bile acids, or they just have the itching, but they don't have elevated liver tests or bile acids, but maybe may develop them later on. And so they have developed groups of suspected ICP, group A, B, and C. And so we looked at these groups in our cohort, and C is kind of the most severe classically of what we think of ICP, where they have high bile acids, high liver tests. And it was almost like a dose response in terms of prevalence of Hispanic ethnicity between the groups. So A had lower Hispanic ethnicity, B higher, and C the highest. So I'm just looking at it now, like 34% of group C individuals were of Hispanic ethnicity. So it's just interesting that it's almost like a dose response in terms of the severity of the suspected ICP with Hispanic ethnicity, the prevalence of Hispanic ethnicity between these groups.
I think it's really important to bring awareness to this topic. I feel like this podcast has already taught me things that I don't know or I didn't know. So, to close this out, I wanted to ask you both a question, a key takeaway question. So, let's say you
Mhm.
both have a crystal ball. What do you hope the
Yes.
next 10 years will bring for rare liver diseases, especially for women?
I mean, I think that we obviously focus mostly on ICP, but this extends to other rare liver diseases like PBC for sure. There's
Mhm.
also PSC, uh, different rare liver diseases. I hope that we continue going in the direction that we're going, where we increase our research, particularly in the pregnancy setting, which I think many women obviously go through and is really important. And we really advance the field so that we improve our understanding, our risk stratification, and importantly, access to treatment for women living with ICP and other rare liver diseases as well. And in particular, that we begin to have a little bit more of an open mind in terms of being able to do research in order to improve our understanding of liver disease in the context of pregnancy.
Andrea, what are your thoughts? What can we do better in the future?
Yeah, definitely more research. We need more research. Miram funds something called ESRs, externally supported research, which can be investigator initiated. We do have a proposal from the UK that we hope that it's been approved. We hope that study will open. It is country specific, but I think even company sponsored studies. I think that I think just because a study didn't work out the way you wanted it to the first time. So the Ohana, our study was a 2A, 2B. It had a dose selection, and then you select the dose and you based on safety and efficacy, and then it's compared to placebo. I think having the courage to give it another go and maybe revamp it, because even every failure can lead to key learnings that can help you be successful the next time. So I'm hopeful that we'll see more research in this area of ICP, both company sponsored and with externally supported research. And I would like to see more education and awareness really to empower women in the voice of the patient. And I think really working with advocacy, I think working with Tatyana's patient who was a neurologist, having her tell her story, Giovanna, having you tell your story. The more that women tell their stories, and they've experienced ICP, they're like, that was me. I went through that. What more can I do? And then it becomes just really then a numbers game. More women are sharing their stories, and then the education gets out there, and then people will come in with the right questions to their OBGYN. They'll share openly. My mother lost 2 pregnancies, and she suffered from really, from itching. And I had an aunt who also had ICP. And what are my risks? And go in armed with those questions to your OBGYN. And that's what I would like to see. I'd like to see the voices of the patients raised up, more stories shared, and advocacy really taking the lead on bringing this unmet need to the broad group of treating physicians, OBGYN. Less so hepatology. I think hepatology is pretty aware. I mean, they
Oh, it
they
depends on who you talk to, but I think everyone can learn more.
okay, fair enough.
I think that this has been an incredible forum for sharing our expertise, your expertise, personal stories. To Andrea's point, we need to continue to do that. And it's not just for us who have the current stories, but it's also for our children as well, who we'll have
Mhm.
to think for our future generation of these issues, especially if they are genetic. And the more prepared
Mhm.
we are and armed with information, the more we can arm future generations. And so I wanted to thank you both again for sharing your expertise and your personal stories. I feel like rare liver diseases might be rare, but as we've learned, they deserve attention. And I really feel like with leaders like you both, who are amazing and also lots of fun off of podcasts and offline, that the future is looking brighter for rare liver diseases and for women as well. So thank you both again for being on this podcast.
Oh, thank you for inviting me,
Yeah.
Giovanna and Tatyana. It's always great, like chatting
Yeah.
with you and learning from
I
you. I
uh,
love it.
I love learning from you. So thank you so much. I've really enjoyed this. Great conversation.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.